So this video is meant to understand a really very important topic, that is transfusion reaction. Now these transfusion reaction actually are the undesired reaction that occur during or after some time of the blood transfusion. Note these transfusion reaction can be either immunologic, that occur because of an interaction between antigen antibody between donor and recipient, or these can be non-immunologic, that is not because of the antigen antibody reaction but rather because of the blood itself. We will study about immunologic reaction in this video, but let's just name some very important non-immunologic reaction. The first one being hypothermia, that occur because patient is receiving blood products at really low temperature than his core body temperature. Electrolyte abnormality like hypokalemia, hyperkalemia, hypocalcemia, and metabolic acidosis, alkalosis are well known. Iron overload is well known in patients receiving repeated blood transfusion, as in thalassemia. Blood-borne infections are the reason why we are going to screen patient for HIV, HBV, HCV. TACO, now you need to remember this, that TACO is also non-immunologic type of transfusion reaction, that is transfusion associated cardiac overload that presents with cardiogenic pulmonary edema. So let's study what we are going to study, that is the immunologic type of transfusion reaction. Now immunologic type of transfusion reaction, we'll try to understand four things about every reaction that we study. These four things are the timeline when this reaction is going to occur after the blood transfusion is occurring. The second thing is how it is occurring. The third thing is how it is going to present. The fourth thing is how we are going to treat and prevent this condition. So let's start with the reaction which is really very fatal and is the earliest to occur. Okay, this reaction that is earliest to occur and is the most fatal reaction is actually the anaphylactic type of transfusion reaction. These are going to present within seconds to minute, that is very suddenly, and in case of blood transfusion specifically, you're going to see an anaphylactic reaction in patients who are having hereditary IgA deficiency or have antibody against C4 heptoglobulin ethylene oxide. We will have classical feature here again of anaphylaxis. The patient will have angioedema. You see in this image, patient has swelling in lips, the periorbital region beneath the skin is having lot of swelling, and the patient can have respiratory distress syndrome. Patient will have tachypnea, grunting, an increase in respiratory rate. A classic patient of shock in case of anaphylactic reaction will have tachy followed by bradyarrhythmia, global hypotension. This was a previous year question. A patient will have increased lactic acid because of anaerobic oxidation. Later, the patients streamline the blood into the vital organs. This is going to lead to oliguria and decreased splanchnic circulation. Either cold or flushed extremities depend on the type of the shock we are having. Altered mental status is another thing that is seen in patients with shock. This type of anaphylactic reaction where we have global hypotension, okay, but the periphery neurogenic system is all right, we are going to have cold extremities. Okay, what we do in these patients is, what we do as soon as possible is stop the transfusion. That is the first thing we do, followed by injection epinephrine, giving antihistaminics, and you treat the hypotension by giving lot of IV fluids. Okay, what we can do to prevent this condition now is you can give IgA deficient plasma, as it is known to cause because of IgA, or you can use washed cellular blood components. Okay, so this was about the first reaction that is really very fatal, that is the anaphylactic transfusion reaction. Now the next, that is actually the milder form of the same, you can say, is allergic or urticarial transfusion reaction that presents within 2 to 3 minutes of transfusion and occurs because the recipient actually has the mast cell with lot of IgE that actually can recognize donor components. Now donor component being recognized by the IgE leads to this allergic or urticarial reaction that presents with urticaria, that are erythematous evanescent lesions over the skin. there will be flushing and there will be pruritus. Note how in this condition also we have to stop the transfusion. This is because in initial stages we cannot differentiate whether the patient is having anaphylactic reaction, allergic or urticarial reaction. You need to look whether a patient with allergic or urticarial reaction can develop anaphylactic reaction or not. You also give IV fluids in this patient. Okay, these are the two important reaction and are related actually. But note how anaphylactic is seen in patients with hereditary IgA deficiency. Now let's talk about the condition that is the most common of the all immunologic transfusion reaction, occurring in about 90% of the patients with blood transfusion reaction, is the febrile non-hemolytic, not non-hemolytic transfusion reaction, are the most common blood transfusion reaction which present within 6 hours of transfusion. Now we don't actually have lot of symptoms, but since the patient is febrile, we can have fever and chills in this patient that are commonly seen in patients after 6 hours of blood transfusion. Okay, the reason behind this is patient have two kind of antibodies. The one that are directed against WBC, that is anti-leukocyte antibody, and the another that is directed against anti-HLA, that are anti-HLA antibody. Note also, this is because the febrile non-hemolytic transfusion reaction can also occur in patient who have cytokine accumulation in stored blood. Stored blood is known to accumulate cytokine and that can lead to febrile reaction. Okay, in these patients too, we just give antihistaminics and antipyretics. In really very severe cases, we stop the transfusion. Otherwise, most of the cases of febrile non-hemolytic transfusion are managed with antipyretics and antihistaminics. Note one more thing: you cannot give the antihistaminic and pyretics through the same IV line that the patient is receiving the blood. You need to have another line for that. So we studied about 3 reactions and how they are going to present, how we are going to prevent. One more thing we need to know is the prevention of this febrile non-hemolytic transfusion reaction, in which we are helped by this leukoreduced filter. Now this leukoreduced filter actually has a filter, you see, this is the filter, and what it does is it filters the blood, and this filtering reduces the febrile non-hemolytic transfusion reaction. It also decreases the alloimmunization to the leukocyte antigen. One very important thing we need to know is it is going to decrease the transmission of CMV in patient receiving solid organ grafts, chemotherapy. Okay, this is important that the patient is going to have decreased transmission of CMV because of leukoreduced filter, but other infections, all the infection like bacterial, parasitic or the other viral infection are not going, all the infection cannot be reduced by leukoreduced filter. Okay, that is an important point, but it is really helpful to reduce the febrile non-hemolytic transfusion reaction. Let's continue to understand a really very important thing now, that is how a patient with hemolytic transfusion reaction is going to present. Okay, a patient with hemolytic transfusion reaction. Now we have two kind of responses here. The one having IgM antibody and presenting within 24 hours is acute hemolytic transfusion reaction. Another that present within 24 to 2 week is having IgG antibodies, is delayed type of hemolytic transfusion reaction. In this delayed type, we may see anamnestic response because of secondary exposure to the same antigen that leads to a increased expression of the antibodies, and this you see is an anamnestic response in delayed type of hemolytic transfusion reaction. Let's start with our men. Okay, that will help us in understanding the acute hemolytic type of transfusion reaction. You see our men is having one hand over the head and another over the flank region. This is because he is having problem in head, that is he is having a feeling of an impending doom. He has high fever. Okay, Another one in the flank indicates he is having flank pain, and along with flank pain he has hematuria, renal failure, and back pain. Okay, these are the classical symptoms you will see in a patient, and a clinical scenario will be directing you towards a patient who is having back pain or hematuria or renal failure or flank pain. The patient also has a Coombs test positive in this case. Okay, this is our men that is having a hemolytic transfusion reaction. Now, let's understand what is the pathology behind the acute transfusion reaction. That is ABO incompatibility. Now we know that a type 2 hypersensitivity reaction has a free antibody directed against the fixed antigen. This fixed antigen is over the RBC of the recipient. So free antibody that comes via donor goes to a recipient RBC and hemolyze our RBCs. That is a type 2 hypersensitivity reaction, well known as ABO incompatibility, that presents with intravascular hemolysis, hemoglobinuria. Okay, this reaction and understanding of acute type of transfusion reaction is really very important. What we do is that first thing first, we stop the transfusion as soon as possible. Okay, and you have to give an aggressive IV fluid management in a patient with acute hemolytic transfusion reaction. Let's try to understand a bit about the delayed type of reaction. That is, the patient is going to have an anamnestic response as we studied. It is because of IgG and occurring within 2 weeks. You see, the patient can have hemolytic anemia again. Coombs test will be positive in this case also, and we can screen for new antibodies when the patient develops an anamnestic response. You give supportive care, and patient may again require the correct transfusion when the patient's vital are stable. So these were the 4 reactions that we studied: anaphylactic, allergic, febrile type of non-hemolytic, or febrile hemolytic transfusion reaction. Another 2 reactions that are mighty important are Trali and Taco. Now Trali we study under the immunologic reaction because it is a condition that is immunologic because of an antigen antibody interaction and presence with a non-cardiogenic pulmonary edema, whereas Taco is a non-immunologic reaction presenting with cardiogenic pulmonary edema. Let's try to understand now the Trali and Taco difference. So Trali, actually we study, the first thing is that Trali is going to have antibodies because it is immunologic. So donor is going to have anti-HLA or anti-HLA type 2 antibodies. These antibodies are going to bind to recipient's WBCs. Okay, and this binding of these antibody to recipient WBC leads to a non-cardiogenic pulmonary edema. Note, we are going to have a transfusion related acute lung injury here, and this acute lung injury is going to present with 2 things, that is bilateral chest x-ray infiltrates, and the patient is going to have dyspnea. Now this is the point where we may misdiagnose the case of Trali versus Taco, because Taco is a condition which occurs because of massive blood transfusion. We are going to have volume overload and cardiogenic pulmonary edema. Now note, cardiogenic pulmonary edema is again going to present with bilateral chest x-ray infiltrates and dyspnea, a point where we may misdiagnose the case. So Trali has some more feature which help us, and Taco has some more feature which help us. A Trali patient, because of these antibodies, is going to have hypotension, and because of this interaction will have fever. Contrary to this, a Taco patient is going to have hypertension. The classical feature which will be given in a clinical scenario in your question will have a patient with an increased JVP if he has Taco. He will have increased BNP in Taco. He will have a decreased ejection fraction in Taco. So we are trying to understand this thing we are trying to understand it together, that Trali and Taco may be confused because of dyspnea presentation in a patient receiving blood transfusion, but increased JVP and decreased ejection fraction will classically point the diagnosis of Taco, whereas a hypotensive patient with fever, chest x-ray infiltrates and dyspnea will tell you that the patient is of Trali. So these were bits about the immunologic types of transfusion reaction. We have another video for the non-immunologic reaction. Hope you liked it, and thanks for watching.